what inspired to take up these specialties? So would you like to go ahead first, Dr. Chandrika?
Oh, hi. Thank you for inviting me to be here. I think my journey to come to the UK or to go abroad actually started in 99. I had been working for a few years as an assistant professor of surgery in Chennai. And I happened to be, the desire to come abroad and get some training abroad was always there much earlier, as soon as I'd finished my master's over there. But I think I did a few years of working. Personal circumstances didn't allow me to leave straight away. But then, of course, after a few years of working, which I think turned out to be for the better, I happened to be working with somebody who was working in doing a few vascular work, and vascular surgery was in infancy in India, particularly in Chennai, I would say. And therefore, I thought I'd come abroad and get some training, found some good people I needed to work with, and that's how the journey started.
Oh, that's really lovely. Okay, so what do you love most about your field? So you work in vascular surgery right now?
I used to work in vascular. I don't. I'm kind of given up a little bit of vascular. I'm moving more into general surgery at the minute. So I do a lot of everything else. Having trained in India, I do have the experience of having worked in all the fields. So yeah, I work in different things at the moment, general and colorectal at the minute. Yeah.
Oh, that's amazing. Thank you so much. What about you, Dr. Manikandan?
Okay, good afternoon, everyone, and thank you for the organizing team for inviting me for this wonderful get together. So, to tell about me, I never had any idea to come into the UK at all. I did my UG and then general surgery training from Coimbatore. Unlike any other surgeon, I also gave my MRCS exams, cleared my MRCS exams, and then went ahead to do my super specialty training, MCH in GI surgery at Amrita. And for some reason, from 2013 onwards, I was always involved in, I had passion and interest towards transplant surgery. And that's the reason why I took Amrita as my college to do my MCH, where I got exposure into multi-organ transplantation. So when I was in Amrita, all my senior consultants in the Amrita were all UK trained in the field of transplantation. And when I discussed with them, they told, apart from the UK, none other country in the globe has a proper structural plan in the field of transplant surgery, both for the transplantation program as a whole and as well as for the training. And that made me use the chance of me having an MRCS, because I had an MRCS before. I used my MRCS to get my GMC registration, and then fortunately I got my first placement in Cambridge University Hospital. So I came there as a senior fellow in HPV and multi-organ transplant. So I was there for 1 year and then moved to Royal Free. Again, I came here with the plan to stay for 1 year, but for somehow this country doesn't leave the people move out of this for various reasons. One might be family interest, personal life, quality of life, whatever. And then I moved to Royal Free for the last 2 years now. Still, I am in a dilemma of going back to the country or not. So in the meantime, I thought I should keep my options open. So I did my FRCS in general surgery and transplant, and trying the most difficult pathway of Caesar route to get the specialist registrar thing here. And in another 1 or 2 months, I might become a locum consultant here, for which specialist registrar is not needed. But hopefully in another next 6 months, I will enter the specialist register and might get a chance to become a substantive consultant here. This is my path.
That's quite a journey, sir.
Yeah.
That was, wow, long and wow, very ambitious.
Yeah.
That's great. Yeah. Thank you, sir. So what about you, Dr. Sanjeev?
Yeah, so I mean, I'm different to most of your panelists here. I was only born in India, but when I was 6, they kicked me out. So I grew up in the Caribbean, and I trained in Jamaica and Trinidad and you had to go abroad. I decided to become a surgeon very late in my life. I was 6, and I decided I wanted to be a surgeon, and there were no other career options for me, really. I wanted to be a neurosurgeon, got into neurosurgical training, and after 6 months didn't like it. So I thought, nope, accidentally walked into a plastic surgery theater, saw micro instruments, and the rest, as you say, is history. Yeah, I like mangled limbs. I like broken upper limbs and lower limbs. That's what I do predominantly. I don't do cosmetic surgery. I'm not slagging it off, but that's not my thing. I use my practice to do charity work abroad, because plastic surgeons are the last general surgeons. Where our surgery was born in the war in this country. And the oldest surgical text written, the Susrita Samhita, the very first operation was a plastic surgery operation, which was a nose reconstruction, which is still done now in exactly the same way. So I figured, hey, this is my thing. So that's where I am now.
Wow. So that's quite a bit of facts about surgery there. Wow, pretty interesting, sir. Yeah, thank you. So what about you, Dr. Manjula?
Hi, first of all, thank you for inviting me. So I was born and brought up in Malaysia, but I did my primary qualification at the University of the West Indies, Trinidad. And following that,
sorry.
So following my primary qualification there, I did my internship. So I had my limited registration from GMC from there on. After that, I was in Malaysia for a few years doing postgraduate in Obs and Gynae. And it was just because I had the limited registration, it was just easier for me to come straight to the UK and get the full registration and start working here. So it was just an easier journey to come to UK than to go to any other country. And once I was here, I just joined the training program. And I got my CCT and became a consultant, was put on the specialist register and became a consultant.
All right.
So that's my journey.
Thank you, ma'am. So what do you love most about what you do right now as an obstetrics and gynecology in the UK?
I've always loved this field. From when I was a fourth year medical student, I always knew I was going to do Obs and Gynae. In UK, you have a very diverse subspecialty in Obs and Gynae. And you can choose to go to areas that you like. You don't have to actually do everything in Obs and Gynae. So it was easy to pick things that I liked, and I'm doing what I like. So that's really what matters, I think.
Right. That's so true. Absolutely. Thank you so much, ma'am. What about you, Dr. Kravitz? I mean, you are from Ukraine. I mean, the part where you began your journey abroad doesn't come up here. So what inspired you to take up your specialty, and what do you love most about what you do?
Thank you for the invitation. I dream to become a surgeon, a cardio surgeon from childhood. After school, I entered to medical college and started to work during education in the clinic in cardio-surgical department. Worked there 10 years. During this, I entered to medical university and worked there. But during education in university, I decided to become a general surgeon. But half a year I worked in cardio surgeon department in Kiev, and it was difficult to change my decision. But I returned to general surgeon, and I work now and study student now. Never thought that I could be a teacher in university, but I tried to do it, and 4 years I worked, and my dreams come true, and I work about it right now.
Okay, that's brilliant, sir. Yeah, I see how everybody started off with one place and just life took you elsewhere, and it's all been brilliant anyway. So that's a wonderful journey, so varied. So yeah, so moving on to the next question. Very often our students get confused as to what the ideal time is to go abroad and pursue further studies. Some say it's best after finishing PG here, while some prefer right after UG. So what would all your opinion be on that? Dr. Santi, would you like to go first?
Yeah, I mean, obviously it depends very much on personal circumstances, doesn't it? But in my opinion, I think the earlier you come to try to get into a system, the easier it is to actually get into it. Yeah, the later you come, the harder it is to sort of slot into the system, and you find it more difficult. So I think people who come straight after undergrad do essentially the equivalent of internship. In where I grew up in Trinidad, we had internship. In India, you have internship. In the UK, we call it foundation years. I would suggest start there, but it doesn't mean that if you come later, that's impossible. But I would recommend starting earlier, the better.
Okay. So like the earlier you get into the system, the more used to it you get and the more familiar you are with everything.
Exactly. We have a lot of Malaysian people who actually come across to the UK and do their medical school here, which is obviously quite an expensive affair. But the earlier you get into any system, anywhere in the world, the easier your path will be.
Right. Sure. Yeah. So what would your take be on that, Dr. Manjula?
So
Sorry.
So in obs and gynae, I think there are two ways of entry into UK. One is undergraduate, which is probably the better way to come into UK, because you do your PLAB, you get your registration, and then you can start from our speaker said earlier, you start from foundation year, and then you get into the system, you get into the training program, and you complete, which is a good way to get into the system. If you come in the postgraduate, there are other ways of entry, but that's a little bit more complicated. So you have to sort of do your postgraduate, and then you contact the Royal College of Obstetrician and Gynecologists, and you have schemes where you can, it's called MTI schemes, and they interview you to see if you can come in through that scheme, and then you sort of work here for a couple of years, and then you're on your own. So you're not in a training program, but you sort of get on, for first 2 years, the Royal College will give you a placement, and you can start working and getting your experience and all of that. But it's meant for you to sort of leave after 2 years. You can stay on if you want, but then you're on your own. You don't have any formal training to go through.
Right. Okay. So it's better if the better option is to move after UG course.
I think undergraduate is probably, when you finish your undergraduate, is probably the best time, because then you're in a system and you follow the, you have logbooks, you have certain things that you have to do, and you do the right process, you go through the correct process. Things become easier that way.
Right. True. Right, ma'am. Thank you so much for your perspective on that. Dr. Kravitz, what do you think about this?
I agree with the opinion that if you want to start something, you have to start it earlier than you can, because our life is not so long as we want. But if we say about postgraduate, when you already realize seriously realize your work, and you have experience both in practice and theory, you have a scientific approach, you can start your work in any country, but you have to be ready for all problems which you have to decide. It's my opinion.
Right. All right. Thank you so much. What do you think about this, Dr. Manikandan?
So from my point of view, it all depends upon the interest of the candidate. So first of all, what is your plan? So if your plan is open, so if open in the sense you can settle down in the UK, or if you want to come back to India, or if you have no plans, then I would suggest that you should come at the earliest. So finish your undergraduate, come into the UK, clearing the PLAB exams, do your FY1, FY2, and specifically for surgical training, do your CT1, CT2. By the time finish the MRCS, and by the time you get into the specialty training, you have all your logbook, all your paperwork's done. But if you come after your general surgical training, it means the post-graduation form from the surgeon's point of view, it's a general surgical training. The option is you should have an MRCS, or a PLAB you need to clear. So clearing a PLAB after finishing general surgery exams is difficult, I would say. You should go back to your undergraduate school and learn many things, which would be difficult. On the other hand, if you finish MRCS, get your GMC registration, come in, getting straight into ST3 and specialty training again is difficult because for some reason we don't maintain the paperwork or the logbooks which is required to enter the ST3 here. So we all, at least nowadays, we all maintain a logbook, but that alone is not required for ST3. They need so many feedbacks, so many paperworks to be done, which I am also not clear about. So entering ST3 at that point will be difficult. And I know many of my colleagues who came in after their general surgery training struggle to enter ST3, and then they go back, start from some has started even from FY1, to be very honest, and some have started from CT1. So, but on the other hand, for postgraduates, if they think that they want to come and do some specialty training, so clear MRCS. That's why I suggest for any general surgeons, do MRCS for whatsoever. It will help anywhere in the globe. So clear MRCS, get GMC registration, select some specialty, whichever you are interested. Come here as a senior fellow, or you can take the option of an MTA. This MTA option doesn't need an MRCS degree. Also, just come here, specialize yourself in a particular field. Like Dr. Manjula told, each hospital handles very specific specialties. For example, in general surgery, we have specific hospitals dealing with inflammatory bowel disease, specific hospital dealing with intestinal failures, specific hospitals for transplant. So you select one specialty, come in there, work for 1 year, and go back. So that is the other option. The toughest route, which I am trying to take, is I did all my super specialty training, came here, I don't know what to do now. For some reason, I'm having an interest to stay back in the UK. At the same time, I want to go back to India. I really couldn't decide because in this stage, I don't want to go back, start my training from ST3. So what I am trying to do is, I have done all my training back home, which is enough for here. So I'm trying to prove that all my Indian training is in par with CCT person here, which we call it the Caesar route, which I am trying to do. Again, the success rate of those things is very, very less. So nutshell, if your options are open, plan from your final year MBBS, prepare for PLAB exams, don't waste for NEET exams, don't waste time. And again, I'm telling you from the candidates, whoever has written the PLAB exams are much, much easier than the NEET exams. So plan earlier, come here quickly, and then you can have your options open.
That is such great advice, sir. And since you know people who've been through the various steps and you yourself have been through quite a long journey with this, that's amazing advice to have. Thank you so much. So we have Dr. Chandrika left to tell us about what her thoughts are on this. Dr. Chandrika, could you please?
Can you hear me?
Yes, we can.
Sorry. The reason, I kind of agree with what Manikandan said and what Sanjeev said in the beginning as well. Essentially, it kind of all depends on what plan you have. If you have no plan, when I say plan, basically, do you want to settle abroad or do you want to return to India? That's kind of, and it's a difficult decision to make, and decisions will always change with time as well. But if you have a plan that you would like to settle abroad, I agree that you can, the earlier you come to wherever you want to settle, that'll be the first thing to do. But if you think you just want to come here for the training and come back, suppose you have a hospital or something set up back home where you can return to, like a lot of people do, then I guess I would say get the postgraduate degree and then come, because in my opinion, I think I don't know much about, I wouldn't say that our trainees get a lot of surgical training because it's not a very structured program. It kind of depends on which college, who's your professor, who you work with and how they like you. And, there are lots of factors in India. because it's not like you need to do X amount of surgeries to get your MS and all that. So there's lots of variabilities on that, and depending on which college you study, with whom you work with and all that. But having said all that, I think diagnostic skills wise, we are pretty good there. You get a very good training over there. So I would say if you're coming just for training, it is very good to do your post-graduation over there and then come. Like Manikandan said, yes, it's a difficult process to go back to starting a training. So one thing you have to remember is learning is lifelong. One doesn't, there is a slight arrogance in a way, I don't know what better word to use, that we all think as soon as you've done your MS, you can do the Whipple's pancreatic audiotonectomy next day. That's a kind of arrogance we all grow with. I'm definitely in that group as well. I'll include myself there. Although you'd have only probably assisted in a case or so, but you just think, oh yeah, I can get to do that. But the reality is, how many cases can you do? Even doing a hernia, you need to do it perfectly. That's probably where you need to concentrate on. And I think we all come out with this false thinking that, as soon as I've got my MS degree, there I am the consultant, I'm going to be there. And that's not true at all, So I would say, yes, if you want to be a serious surgeon, I think get best of both. Maybe get the postgraduate degree over there if you can, because it does help a lot. You do become a little bit more wiser as you go along, and then you can also choose your super specialties as you come abroad. But again, if you have no plans at all and you're open to doing anything, well, come early, as they all said.
All right.
Can I just say, Tanya, that
Absolutely.
I've been a training program director in plastic surgery in Yorkshire in the past. And one of the things that I've seen with people who come from abroad, especially the Indian subcontinent, is that they come and they're very good with their hands, and they come across and then they find it difficult to be in the same senior position they were in when they were there. And there's a lot of frustration that people go through. So if you come and you were, I don't know, I'm not sure what the system, say you're a senior resident, you've done your MS and whatever in India, and you're doing all these procedures, and you come and then you become an SHO in the UK, it's a big step down for people, okay? And as surgeons, we all have surgical pride, yeah? So that's one of the things. If you're gonna come across, and you then come and become an SHO, and then you have to do stuff which you think is now beneath you because you have gone forward, it can make life very difficult, okay? So the later you come, the more you have to be willing to swallow your pride. Because I don't care where you come from, you come to my unit, I'm not gonna let you cut someone till I know you can cut them properly, okay? And everybody goes through that. And if you come early, the good thing is that you become part of the system, and the system you are then recognized as itself. So you're not an antigen that antibodies are produced towards. You get very friendly thing. But absolutely right, it's either thing, but you got to know the pluses and minuses of both, yeah?
Yeah, well, we do now. Since we've had such varied perspectives, we know there are, we know the pluses and the minuses, absolutely. So thank you so much, panel, for these. Well, moving on to the next question. So we know the surgeons here in India, they follow a very hectic schedule. I mean, I've seen surgeons work for more than 48 hours straight. While NHS is known to be considerate when it comes to a work-life balance with fewer working hours on paper, a surgeon's job mandates that they be there whenever a case comes upon, So how many times did you all have to go out of hours to operate and take time out? Dr. Manjula, would you like to begin?
Well, in obstetrics, we tend to do a lot of on-site on-calls because of the nature of the job. Yeah. So when I'm on call, we don't have to go in for every surgery unless you're on call. And even then, when you have senior registrars who can do the job, you don't actually have to go in. If it's a straightforward, say, cesarean section or something like that, or a laparoscopic salpingectomy for an ectopic pregnancy, you don't have to go in if you have senior registrars who are capable of doing it. If you're on call and you are called, you have to go in. So for obstetrics, we are on call on site until 10 p.m. at night. So if anything happens, I'm there and I go in surgery at the time. After 10 o'clock, I will be on call over the phone from home. And most of the time, the senior registrars are able to manage a lot of things. If it comes to a point where they need me to come in, I will have to go in while I'm on call. And that's the way it works here. But once I'm finished, like if I'm finished at 8 o'clock the next morning, then they don't have to call me and I don't have to go in. And very, very rarely when another consultant is on, and if they have a very serious critically ill patient and they need another consultant to come in, and if I'm not on call, they can call me and I can go in to help them. So when I've been on call and I've been at home and they have called and I have to come in, that has happened maybe twice a year. So it's not very often. And where another consultant has needed help and I've had to go in, maybe once in 2-3 years. So very rare.
Wow, but that is very rare. Yeah, that. So it seems like you do have a really nice work-life balance.
Yes, in the UK, you do have a very good work-life balance. When you're on call, you have to be responsible and you have to go in. But when you're not on call, you can just switch off your phone if you don't want to answer any phone calls.
All right. That's great. Is that the same for you, Dr. Kravitz?
I worked in different hospitals in different times, and as younger you are, you spend a lot of time at work. When I was on my internship, I lived in another city, and I worked over than 100 hours a week. That's why it was very difficult. Now I work in big hospital, but I work with professors and big clinic. We make not big mistakes in practice, but we have specific in Ukraine. We all time on our phones. That's why we have online consultation before lockdown all over the world. We have calls at night, during our work day, on weekends, on holidays. That's why we all time on our work. But calls from hospital we have 2 or 3 times a week. That's why it's not a lot, but I'm now a young specialist. That's why I think in future it will be not so many.
Okay. So you're saying with time it gets better and you would have lesser hours the more senior you are. That's how it would be. Yeah. Okay.
Yes.
So Dr. Manikandan, how are your work hours?
I think I am not the right person to answer this question because our department doesn't have timings actually. So because I work in liver transplant, it all happens as emergency. Similarly, organ procurement surgeries can happen at any time. Although we have rotas covering situations like, rotas covering the liver transplant, rotas covering the retrievals. There are many situations where simultaneously 2 transplants will happen and there'll be only 1 team. So we need to have at least 4 or 5 extra surgeons volunteering in one. Secondly, many of our HPV surgery cases, liver cases or pancreas cases, are usually on an average takes between 6 to 8 hours. So although if we say my working hours is between 8 to 5, majority of my surgeries, if I am operating on that particular day, will end at 9 o'clock or 10 o'clock in the night. Similarly, when I go for retrieval, although it is a 24-hour shift, if I am called out, say at the early morning, when my shift is getting over, I have to go out to some other part of the country. I have to finish my retrieval and come back. It will be more than I'll be working continuously for 36 hours also. But this is this specialty. So we should not blame the specialty because I opted for the specialty because I am interested in the specialty. But majority of other specialties, the system is devised in a way that people don't work more than 40 hours a week, with some exceptions, like you can go up to 48 hours or 50 hours, which I am not sure. But from my point of view, I don't have specific timings for myself. At least almost every day, I go out of hours, almost every day, including the weekends.
Oh my. So transplant surgery is something that takes a toll
that is
out
my
on you.
interest, and I love that. I love that.
Okay,
It's not.
well,
I'm not blaming anyone.
okay, that's
Yeah.
great then.
Yeah.
Wonderful. What about you, Dr. Chandrika?
Well, I kind of agree with what Manikandan says. Again, it's all very specialty dependent. Suppose you choose to work in what's called as a breast surgery, you probably will not have any on-calls at all. You're just doing a 9-to-5 job, which is what a lot of people use. Perhaps even urology, if you go into that, you're probably just doing more or less, you're probably a name on call, but you don't really get called in that much. But I personally, I mean, at the moment, when I'm doing general and colorectal as on an emergency call, I'm doing like a 1 in 8 on call. So on the days I'm called, I have to be available. It might be to be called into hospital or to even answer the call on the phone. So the nights I have to dedicate to my work. I have to be able to take the phone calls, give them advice, or even being called into hospital different. The days when I used to do vascular surgery, I mean, I like the previous speaker said, it's my personal interest. I wanted to be there for the cases. So aortic aneurysm ruptures can come anytime. So if I want to be there and I want to be on the case, I have to be available to go in anytime. So there have been days when I've literally been in hospital like 3 times a week or something. And there will be days when you don't get called for 3 weeks, So it kind of varies. I would say it varies a lot with the specialty you choose. So people, if you're looking to strike a work-life balance, I mean, I have worked in cardiothoracic before in Germany as well. And the thing is, if you do cardiothoracic, you're literally 24/7 in hospital. And that was one of the reasons I didn't want to stay along in cardiothoracic surgery, because I did want to, I do enjoy going to the beach or watching the sunset and stuff like that. So, I just decided maybe that was not for me. I wanted a little bit of life as well, even as I was young, so that's the thing. And it depends on how much of a dedication you want and how much of a life you want. So it all kind of varies a little bit with the specialty, I would say.
Oh, well, so with general surgery, you're having a very nice time.
It is a relatively easier way. I mean, I say like I'm not really getting called like exactly how Manjula said. If I have a very senior registrar who's there, who's capable of handling things, I probably just need to give some advice over the telephone. However, it's not always the case that you'll have a senior registrar with you. You could have a very junior registrar and you've got to teach them as well. Teaching is part of the job, as you know. And I will have to go in. It depends on whatever the case is. Even if they're doing just an obstructed inguinal hernia, which is what most people will be able to do, or even an appendix. If they say, right, I can't manage this appendix, can you come in and all that, you have to be there. Or if they're not confident enough, I mean, you just have to be there at least physically. So it kind of varies a little bit. But weekends, I would say like 1 in 8 weekends is what I need to be on. So like I said, it all kind of depends a little bit on the hospital. Again, I've worked in hospitals where you won't get called at all in the night, or there are some hospitals where you're literally living in the hospital. So it does vary a little bit that way. Well,
so it's all relative.
Relative.
Depending on the hospital, the specialties, right?
Yes.
So how's plastic surgery treating you, Dr. Sanjeev? I hear you have wonderful juniors. How's the department being for you?
Yeah, I guess the first thing to say is that in the United Kingdom, the European Working Time Directive doesn't actually, it's not applicable to consultants. Okay, that's really a junior thing. So consultants don't work the 40 hours a week that our juniors work. So that's the first thing. And the second thing is the whole work-life balancing is a myth. Yeah, I don't believe in a work-life balance, because work is part of your life. I enjoy my work, so that's part of my life. So I consider it a work-leisure balance. Okay. Thirdly, if you're really that concerned about work-life balance, perhaps surgery is not the job for you in the first instance. okay? So if you walk into surgery thinking, how little work can I do? How many hours can I sleep at night? Perhaps not the best job for you, I would say that. Given that certain subspecialties, I mean, breast surgery is not a subspecialty, especially yet, but it will be. They don't have on-calls, I can grant you that. Having said all of that, I love what I do. I completely adore what I do. And like Confucius said, if you love what you do, you don't work a day in your life. So I really love what I do. And the final thing to say is when a patient of mine goes into theater in the middle of the night, I have to come in usually. It's either neck fash, which is a life sort of life-threatening infection, or someone who's lost a finger or a hand, or someone is bleeding. Like the general surgeons in my hospital, the general surgery consultants are always in. They have a really hard life, actually. And I'm sure Chandrika knows that it's difficult. So yeah, it's all difficult. If you want to have a really easy life, do psychiatry, I would say.
Okay. All right. Thank you, Dr. Sanjeev. So yeah, I guess since you all unanimously love your fields, there is no issue about a work-leisure balance, as rightly stated by Dr. Sanjeev. So yes, that's great. So another question our delegates posed was countries like US, Australia, Canada, and Dr. Chandrika, you said you worked in Germany, so they all have their perks. So what motivated you to choose UK or Ukraine in Dr. Kravitz's case over the other countries that are quite often chosen?
I was born in Ukraine, and I work here. I love my country, but in my case, I think this issue was decided by financial issues. It's played a lot of because it's difficult to change our country for others. It's cost a fortune for us, but our education give us a job, and we can work here as surgeons, and we can increase our skills here. We can study and work as well as we can here. We can study in our other countries with many ways, but I like work here because when I work in other cities, I saw that many people haven't normal medical hospitals in their cities. That's why when I live in my city, I can go to small town and work there as a surgeon, as a family doctor, and give them help. That's why I like to work here.
That's really great, Dr. Kravitz. So staying true to your nation, staying there, that's amazing. What about you, Dr. Chandrika? You've experienced various countries. What would your take be on this? Ma'am, your audio is muted.
Yeah, can you hear me now?
Yes, we can.
I just keep getting muted for some reason or the other. I don't know. Anyway, I think what I was trying to say was I might have stumbled into UK. A little bit of, I would say it's the part of the colonial hangover. We all think because lots of our bosses have been trained in the UK and they've returned, and you see this, everybody's at FRCS and all that. So you kind of grow up a little bit wanting to do the FRCS, I think. That was there. Again, it is good to have the exposure abroad because there's a lot of way they learn, they teach. All that is absolutely important. I think it's a paradigm change, I would say, from the way we learn and teach over there in India. Not that it's bad there. I would never say that Indian training was bad. It is very good. However, there are a lot of other factors in the practice. And then, yes, financial is one. You do tend to have a relatively easier life for a better quality of life as well. When you come abroad, you're probably in upper middle class as a doctor in the UK and everything. Again, going by the US, yes, I've been briefly in the US as a research fellow as well. But for me, personally, it was more the distance from India. I didn't like, and also, you're kind of working a lot more in the US over there. Europe is good, but languages can be a problem. English is, when we all learn a lot of things in English, so UK does become easier. Australia, I don't have much experience about, so I've never worked there. So I don't know. But UK does strike a good balance in the fact that it's not too far from India, because I do travel a lot to India as well. So it is much easier that way.
All right. Yeah, that makes sense. Yeah. So, Dr. Sanjeev, even you've been to multiple countries. So, what would your take be on this?
Oh, but when I finished my undergraduate training in the Caribbean, my choices were, well, essentially the US, Canada, or the UK. And the decision was pretty simple, really. It's cricket, isn't it? I had to go where they play cricket. I can't go to somewhere where they play baseball and basketball and nonsense like that. So cricket is what brought me to the UK. Never thought of Australia because I would support 11 chimpanzees playing cricket against Australia. I'd hate the Australian cricket team. I hope there's nobody Australian here. So it's pretty straightforward for me. And I guess the thing that also in truth is that with my undergraduate degree from the Caribbean, I didn't have to do any exams to come into the year. I walked in and got my GMC registration the next day. So, which is also a good thing. And then I went and joined the cricket club, which is the second thing. And that's it. That's how it all started.
Okay, so cricket first and then the arts exams. Perfect. Yeah. Sounds just about right. What about you, Dr. Manjula?
Same like Sanjeev, I graduated from Trinidad. So for me, the GMC registration was already there. And it was an easier path to come to UK than to go to USA or to Australia. And I also understand from some family that I have in Australia that to actually get into a training program in Australia is not an easy task. And in fact, we have medical students who finished their training there and they come to UK to get into our training program. So what I understand from others is that to get into a training program in Australia is not as easy. In the UK, I'm not saying that it's easy, but it's relatively easier than Australia from what I've heard. US was not a choice because you have to do US MLEs and all of that. And where I already had the registration for GMC, it was just an easier path to come to UK. So that's really what drove me here.
Oh, that's great. Of course, yeah. Thank you, ma'am. What about you, Dr. Manikandan? You've done quite a lot in UK. I mean, did you ever think about picking
Yeah,
one in
so
the US?
the reason why I don't so I don't have any experience about to me by my senior colleagues one, and what I observed here is also good. Can you hear me?
So your voice is breaking, I think.
Oops.
Can you try now, sir? We could move on to the next question and we'll get back to you, Dr. Manikandan. Would that be okay? Okay, so I'll just move on to the next one. So next one's about some of the advancements in the field of surgery. So the countries you work in are pretty well ahead in time with regards to advancements in the field of surgery. What is something that UK or Ukraine has to offer in surgical training in comparison to the other countries that are there? Dr. Sanjeev?
When you say the other countries, you mean like Australia or the US? Is that what you mean, or do you mean India as the other country?
Yeah, India as well.
Yeah, so I mean, I haven't worked in the other countries, so it'll be disingenuous of me to actually try to answer that in any format, except to say what we offer is structure, and that's the thing we offer for training in this country, okay. And one of the big things I think we offer is learning how to make decisions, and that's one of the things I find with people who come from abroad is they're very good technically, but it's to get them to learn about making decisions which are bespoke to the patient. You learn about MDTs, this and that and the other. So I think we, no system is perfect, but I think our system gives people, what I tell my trainees is that surgery is not really about our hands. Our hands are just our slaves to the thing that really makes it work. It's a cerebral sport is surgery. And I think what you try to teach our surgeons in the UK, surgery is a cerebral sport and your hands just do the work for you. Sort of measure twice, cut once sort of thing. So I don't know if that answers your question, but that's the best I can do anyway.
Yes, absolutely. So the advancement is within us. Something like that? All right.
Sorry, I didn't get that. What did you say?
So we advance with time, like the learning that we do, and then as we practice, we get along with it.
Exactly.
Cool. Dr. Manjula, what advancements have you seen, or what different new things have you seen in the field of surgery in the UK in comparison to the other place?
I think in our specialty, we can do specialized training in certain things that you want to do. You don't have to actually do everything. Like you don't have to do, in gynecology, you have early pregnancy, you have urogynecology, you have fertility, you have so many different branches, and you don't actually have to do all of it. You can actually go into a subspecialty and just train to do that. And you come out of that training being really good at what you do. During the training program, they have something called special skills module. They also call it ATSMs. So you can pick these modules and decide, if you know what you want to do, you can decide to do that particular module and you get really good in it. And by the end of it, you are actually an expert in that area. And when you apply for jobs, you apply for that particular specialty in obs and gynae. So you are not a generalist. You can subspecialize in things and become more of a specialist in that area, as opposed to just a general obstetrician and gynecologist. I think that's really good. And we, like Sanjeev said earlier, we have these MDTs, multidisciplinary team discussions and meetings. And if you have a case that's really complicated, you have these multidisciplinary meetings along with other specialties, who then, you come to a consensus, you discuss the case, you come to a consensus, and you do what is best for the patient. So I think that aspect of things is really good, because you're not taking the whole responsibility onto yourself, and it's sort of a general consensus of everyone's opinion on what is best. So I think those things are good in the UK.
Yes, that seems like a very progressive move in the system. Yes, that sounds great.
I would like to add here, this is something which the Indian surgeons and the medical fraternity of here at India should learn from the international or abroad or UK medical fraternity, because here in India, we lose a lot of patients because we hesitate to ask for help. The surgeons hesitate. Mostly they take up the entire responsibility or the decision making responsibility single-handedly, and then there are cases which then turn to a very fatal conditions, and then fatal circumstances are seen. So this is something coming together and then delegating, and then taking a decision involving different surgeons on board or different doctors on board, and even taking their consultation and their opinion is really important. And this is something which we lack here in India, and we are definitely the surgeons are adopting it, they're adapting it, and we can see many cases wherein second opinion, third opinion, if the patients are also like, taking different opinions, the doctors don't mind, but usually the doctors who are little, like who have been practicing since a very long time and who are seniors, say they sometimes take offense, like, oh, you're second guessing my opinion. So yeah, slowly we'll get there. Thank you so much, Dr. Manjula, for highlighting this point.
Knowing when to ask for help and actually asking for help is not a demonstration of weakness or failure. It's actually a demonstration of wisdom. Okay.
Yes, sir.
And that's very much our culture in the UK.
Definitely. And this is, again, a very good point brought up by Dr. Sanjeev. And I think so the future aspiring surgeons and doctors today who have joined us today, they can learn something. They can learn this really important point and practice and start practicing, not when they become good doctors or good surgeons ahead in future, but right from today. If you need help, you should have the guts, and you should open up, you should stand up, and you should say, yes, I need help. There's no weakness or vulnerability in asking for help. Thank you so much. Dr. Tanya can continue.
In UK, where trainees, when trainees undergo their training, they constantly have a discussion with their educational supervisor, who will assess your training and see what you need to do, and if there's things that you need to improve on and all of that. So they have these educational meetings, and in those meetings, we even talk to the trainees about knowing when to ask for help, knowing your limitations, and so that is part of the training, even from, postgraduate level. So asking for help should not be something that's, I know everything. It should never be like that. It should always be like, okay, I know up to this much. I think I need help. And it should never stop you from asking for help. And that's always been part of the training here.
That's so amazing.
The upcoming training in India, they have come up with a new pattern for the UG undergraduate, and they are emphasizing and including this point. Referral system, they are putting more of a spotlight and putting it that it's an important factor that a referral system should be followed. If you don't know how to go beyond it, then refer the patient to some other doctor or some other colleague of yours. So definitely, slowly, even Indian medical fraternity is learning, and we'll get there.
Hoping we also gain this wisdom to accept what we don't know and get help. Yeah, that's much needed. So, what are your thoughts on this, Dr. Manikandan?
Okay, so sorry, I got cut twice because of my network issues. So for the question, what UK can offer which the other countries fail? First thing, because I had trained in both the government sector and the private sector, the first thing which I found difference is the standard of training. So here, when we say that a student is ST3, at least we can say that at least 80% of all the ST3 will know at least what they need to know. Okay, but in India, we have a huge diversity of training variation between center to center. There are centers where an MS postgraduate comes out without even doing a single hernia operation, and there are not only with general surgery, I would say even with MCH, people come out without doing anything. On the other hand, there are centers where a post-MS surgeon can do surgeries like, say, even a Whipple or a gastrectomy. So there's no appropriate standards which this country has. So like someone mentioned before, so any trainee will have, wherever they rotate, they have someone called as a supervisor, and they have a very strong mentorship program where you go meet them, discuss what is your scope and what is the things. More than that, for each level of training, they have some basic numbers in terms of research, in terms of number of surgeries, in terms of presentations, in terms of publications. And at the end of every year, they have something called as an appraisal meeting where they go sit with the supervisor. They have to fill in that's a huge paperwork which they need to fill in, which includes your personal feedback, your colleague feedback, your patient feedback, everything, including what you did in auditing, what you did in the way of presentation, how many number of surgeries you did, how many number of case-based discussions you did. So you have to enroll everything in your portfolio. So the portfolio gets built up from your ST1 to ST8, and at various levels you have multiple checks to make sure whether you satisfy those needs before you go to the next level. This kind of training is very good here, and I have to tell you that India 100% lacks it. The one area which we are very strong in India is, if you have all your skills as a surgeon to keep your bosses very, very happy, and if you work in a center which has busy surgical cases, then you can become a good surgeon in terms of hands-on. But in terms of research, nothing. In terms of communication skills, nothing. And you just pass out. Everyone passes out. Passing an MS exam or MCH exam is nothing, I would say. Everyone passes out. Again, it varies from center to center. But this standard is what India should learn from the country like UK, although I don't know about other countries like Australia or Canada. And I would like to quickly tell about the previous question, which I failed to answer. The reason why I opted the UK is because of my specialty, because I wanted to become a transplant surgeon. And I should admit to you that India doesn't have a very formal transplant training program at all. The transplant surgery is handled by either general surgeons or GI surgeons or vascular surgeons. And majority of the transplants happening in India are live donations. We don't have cadaver donations at all. But here, the system is completely different. We have specific centers for liver. Like, we have only 6 centers in the entire UK that's doing the liver transplant, only 2 units doing the pancreas, only 1 or 2 units doing intestinal transplant. And we have a retrieval service which is completely separate, which is zone-based. And the transplant program is completely transparent. So the organ allocation happens in a way that the sicker patients receive the organ rather than the closer one or the patient who has registered at the first. So the allocation of organs happens in a very beautiful system. And this system, I am pretty sure it's not even exist in the US, although I might be wrong. But this system, whichever is existing in transplant surgery, it's one of the best in the globe, which I heard from all my colleagues. And if someone really want to pursue the career of transplant surgery, I would advise them to come into UK, train themselves at least for 1 or 2 years before they go back to India. And majority of the successful surgeons in India are all UK trained.
Wow. So what drew you to this country was the success rates and the systems integrity and, well, the integrated approach they have in the system. So that's something every other nation should draw inspiration from, obviously. So,
cricket.
Dr. Yeah.
And cricket.
Yeah.
And cricket, yes, sir. I will mention that. And cricket, most certainly. So, Dr. Kravitz, would you like to add anything about the advancement in the field of surgery that, in comparison to the other countries in Ukraine?
In Ukraine, yes, we have interesting situation with education because we make complex of our historical education by systematic skills in thinking of patients and in European system. That's why we have old system and new system together. Since third year of education, our students, we study all students in one system, no matter what country or Ukrainian or other students. All students since third year of education goes to the clinic. They work in different clinic, in different department. They have to work in pediatric department, surgical, different departments. And they work there. They can stay on duties. They can work with nurses. They can work with doctors as assistants. Since fourth year of education in my department, they can start to assistant as assistant doctor in the surgeon hall. Operation room. They can be the first assistant, second assistant. We studied them, and the 5th and 6th years of education, then they can be as assistants. And I know a few students which we send to hospitals, serious hospitals, where they can work after finishing, after third course, six course, as assistants. And in our department, we leave a few students after graduation. They write PhD and work as a surgeons and write scientific work, and they make surgery with us.
All right, so it is a very well-structured system, and that seems like a very progressive move in your nation. That's
Yes,
great.
very progressive. And now we enter computer system, virtual reality in computers, and they can make surgery in these computers and try to make the appendectomy, cholecystectomy by two students, and they can train it when they want to do it.
All right, that's great. So, moving a little laterally right now from this question, artificial intelligence in surgery is right now being called revolutionary. So, with its advent, what could one expect of the future of surgery? It would clearly not be the same, but how much of a change should one expect with regard to artificial intelligence taking over healthcare and the scope that it leaves behind in the various specialties that are there? Dr. Manikandan, anything pertaining to your specialty in transplant surgery?
So, artificial intelligence, I mean, at the moment, what I think as artificial intelligence in my field is we have quite a number of softwares which makes the very complex liver surgeries much feasible. For example, when we do an extended liver resections, in order to assess the volume of the remnant liver which we leave in the patient, we have specific softwares which tells us what will be the remnant volume, where we'll be cutting through, what structures will come across when we cut across the liver. So these are specific softwares which reconstructs the images and gives us numbers in terms of percentage, that one. And then from the radiology point of view, I think we have so many reconstructive softwares available. But again, robotic surgery, I still consider it as an artificial intelligence thing, and the surgeon sits in a console and we operate, and it in the very near future we will go to a situation where the surgeon will be operating from somewhere with the patient and an assistants in the operating theater. I think it can happen. I think it is happening in some warfield surgeries which I have heard and read, but it might be the future, I don't know, but there are so many restrictions, I don't know. Apart from that, I don't know much about the role of artificial intelligence, where it will take us in the in this my transplant field at least. And one more thing is we have something like a national database here. So what that system does is when a donor comes in, when we have a donor somewhere in the hospital, when the information of this donor is put into the system, the computer or the software decides 10 recipients in the country based on who will be the best match for this donor, even within the same blood group. So we have a system or something which is existing, which helps that. That's it. Apart from that, I don't know what to recollect on this topic.
Okay, so it's surprising to know that it's already happening to such a large scale. And
yeah.
Hopefully for the best. What are your viewpoints on this, Dr. Manjula?
So in obstetrics, I think artificial intelligence has not made its way yet, because it's a very litigation is very high in obstetrics, especially in the UK, and it is difficult to have an artificial intelligence that will, understand fetal physiology and labor and all of that. So I think in obstetrics, it's not there yet. In gynecology, robotic surgery, mainly in like hysterectomies and all, do happen in certain centers, but it's not very widespread yet. And I think people are still very hands-on, and artificial intelligence hasn't really taken over the specialty yet. That's as much as what I can say.
All right. So OBGYN is relatively still a very doctor-patient oriented one with less robotics involved.
Yes.
Okay. So, Dr. Chandrika, is that the same in the field of your work in general surgery?
I mean, in general, I would say, like, you probably may not remember, I don't know, when we were studying, or when I was training, so to speak, laparoscopy was very in an infantile stage in India, and only a few people were learning how to do it. I don't know how things are now, because I haven't actually worked in any medical colleges in India in the recent past. So, at that time, I still remember there was a lot of resistance saying, oh, this laparoscopy is not going to take over. It's not going to do anything big and all that. But now it's like kind of become a mainstay. So similarly, I think, yes, robotics, I mean, when you say artificial intelligence, you're thinking of robotics, and that's possibly where things will go to a certain extent. And it's a new skill set to learn. And I think people will get used to it, although, like I said, from the open to the laparoscopic era, from the laparoscopic to the robotic era, it's possibly going slowly in the direction. It will take time, but that doesn't mean that you will have to let go of your open surgery skills, because again, as you all know, in laparoscopic, when things fail, you come back, you fall back onto the open surgery anyway. So I guess it'll all coexist. You probably will have to be good. Some people probably, like as they say, some people are very good laparoscopic surgeons. They probably don't have that much experience in open. Similarly, it might come to the situation, some people, kind of take very naturally to robotics works. And but again, at the end of the day, you will have to have your open surgical skills anyway, because that's going to be the fallback option, whatever happens. And like Manjula said, I think, yes, robotics is happening. I mean, urology is one place where it's really taken off. They're one of the first people who are using plenty of robotics, I have to say. And then colorectal pelvic floor exentration and all those kind of work, yeah, they do a little bit on that. Again, liver resections has already been mentioned. So those kind of things, I mean, there are certain niche specialties which it seems to help a lot. I guess the problem is not everybody has the exposure, and it's a lot of money. I mean, they're getting the robot, getting the practice and all that, like laparoscopy was in the early days. Robotics, that's probably what the problem is, because not everybody's got the opportunity to go train. And I guess this question might be best answered by somebody who's had a good experience working with robotics as well. Probably it'll be good to get a perspective from them, right, rather than just for us who have not used it, I would say.
Right, ma'am. Thank you. So there is still scope for surgery in the presence of AI, and everybody would still require their skill set to prevail in this field. Thank you, ma'am. Yeah. What do you have to say about this, Dr. Sanjeev?
Yeah, I think it's important to distinguish AI versus robotic surgery. Robotic surgery as it exists now is not AI predominantly, because I don't know if you guys have seen robotic surgery. There's someone who sits in the corner who's a surgeon. And the main thrust of robotic surgery, and they use it for urology cases quite a lot, is that you can put lots more tools into a very confined space like the pelvis. That's where that robotic surgery is terribly important. Okay. Now there are moves to try to get AI involved, but surgery really is divided into three things, isn't it? It's diagnosis, decision making, and technical aspect. And the easiest part of those three is the technical bit. I can teach a chimpanzee to operate. That's not a problem. It's the decision making that's the issue, and that AI hasn't got there yet. In diagnosis, there's more AI involved. In fact, it's quite interesting that only yesterday, on my BBC news thing, there was a clip saying that the Aussies have now started using AI for diagnosing melanoma. So essentially go into a scanner, a 3D scanner, and there's an algorithm. They look at, whatever moles you have and work out, because there's such a thing, those sort of things. We haven't reached Prometheus level AI, like in the movie where you go and sit and RoboDoc does everything for you, right? So we haven't quite reached there yet. So I think AI is very embryonic in surgery generally. What is much more prevalent than artificial intelligence is natural stupidity that I see quite a lot of, and we try to overcome that by artificial intelligence. I'm just funning. Don't worry, I don't really mean that. But yeah, so AI is coming along, but very embryonic. Maybe one of you guys will develop something, because the future is in your hands, isn't it? You know, I'm just waiting to die. I'm old. Okay?
All right. So yes, decision making being a core thing we all depend upon. Yes, hoping AI, assuming AI would not be coming up really soon. What do you think about this, Dr. Kravitz? Have you seen or experienced?
When I saw this question, I was very surprised, and it is very difficult because a lot of questions will be for artificial intelligence. I don't know, it will be very rational or no, because medicine it's not so correct as we want, because most often medicine is based on theory, on our practice and our experience. Yes, we work by protocols. Yes, we make everything by experience of all countries. Yes, and we discuss it on conferences. But in some difficult cases, when we are in the body of our other person, we have to decide by our experience, by all protocols, what we have to do in this correct situation, what we have to do. And I don't know, and I don't think that artificial intelligence without help of people can do this choice, because from our choice in this choice it is life of other persons. That's why I think it will be very difficult, and it will be in future, and even I'm too old for it. That's why I think we will have good assistant in daily situations, in simple situations, in diagnosis, in everyday appointment of patients with simple problems. But in difficult situations, it will be a lot of questions. And I think in some cases, artificial intelligence will ask us how you do it. I think that's all.
So if it were about how, as in, it would still depend upon a doctor's perspective and the decision making at that point. So you're agreeing with Dr. Sanjeev. Thank you so much. Another question a lot of delegates put forth was something that lingers on the mind of a large population of students, especially the female side, is that despite the rising number of female surgeons in comparison to the past decade, the percentage is still staggeringly low at 6.5%. Dr. Manjula and Dr. Chandrika, beginning with you, could you please enlighten us on why this could be and what can be done to rectify it?
Manjula, you want to go first?
Okay, so in obstetrics and gynecology, I don't think that is an issue or a problem that we've seen, because there are lots of female consultants and gynae. And I haven't seen it at answering this question, because I think that happens a lot more in the surgical field rather than in obs and gynae.
Yeah, I mean, yes, I have to say, compared to the past, there are a lot more surgeons, a lot more females who have entered the surgical profession. And obviously, it's, the question of having a family is possibly what interferes with a good number of people, because women are generally the nurturing person, isn't it? So they have to, it's not just having babies, you have to bring them up, to care for them. They do part of a lot of the nurturing, not to say that the fathers don't contribute, but they do have a great part in it. And I guess women tend generally for that reason think they probably can't give that much of time into the tough specialties, like say the transplant surgery, for example, where you're kind of going to be available 24/7, to go for a retrieval and all that. And that's not going to be possible when you have childcare to think about. So I guess that's possibly one of the reasons. But then I have to say I'm talking of surgery over the last 20, 25 years, and there's been a huge number of girls who've come into surgery, taking surgery as a job. And they are in various specialties. They do try to get a work-life balance. I have good friends who are cardiothoracic surgeons as well, and that too in the United States, who are women. So they have managed it. I guess the number will always be less. But I guess it's a kind of, this women tend to gravitate into jobs which will give them the time with the family. I think it's just the nature of being a woman. So I don't know, to be very honest, whether there's any other way of encouraging them. Here in the UK, they're quite liberal with their maternity leave and things like that, which I kind of have a bit of a fuss about as well, I have to say, because that just leaves the others to take over the job. But again, it is what it is. And, yes, they have to be given the choice, and they do. So sometimes you'd find a girl who's entered for the ST1, and then they go on to have 2 babies. And by the time they are really out to finish, they're probably about 10 years into their training program, or 10 or 12 years, so they've just gone on, taking time off. So, it does cause a bit of a trouble. So I guess that kind of plays a factor, but to be honest, I don't know what else you can do to encourage. The UK is quite encouraging that way. I wouldn't say that much about the other countries. I don't know how it is in India, but here definitely, I think lots of women do come into surgery, and they are quite well supported.
All right. Well, you all are a very big inspiration, because out of the 5 panelists, we have 2 who are females over here, and the situation is in India is actually quite worse. It's much lesser, the ratio. So hoping that changes. And Dr. Sanjeev, do you have any thoughts on how we could change that?
Yeah, I'm a plastic surgeon. More than 50% of my registrar trainees are women. Full stop. Okay. So I have a big problem with women not joining surgery. In the United Kingdom, 70% of medical students are girls. Yeah. And if we have only a small percentage of them joining us, then I'm not getting the best of the crop. Okay. I don't really care if you're a man or a woman. I'm more interested in what kind of surgeon you're going to make. Okay. So, Chandrika is very right. It is different, isn't it? Every human being has their own challenges when the wife brought me coffee. Give me a second. Thank you very much. I also make her coffee sometimes. So before you guys start to work out any kind of issues there, okay? So when she does her conferences, I bring her coffee. Anyway.
This is really ironical. You're answering a question about women in surgery, and
that was really bad, wasn't it? That was the subservient Indian woman coming with coffee. She's my niece.
Timing was impeccable.
No. She's
the point.
She's my anesthetist, and I get her a latte every single list. I have to go and get her latte for her. So don't give me any of that. No, just to get back to the point of women in surgery, is that every human being will have their own challenges, and you have to decide on your compromise. Manikandan said very well. He said he chose his specialty. He knows it's difficult in terms of time. Okay, you can be a surgeon and decide, actually, I will do breast surgery. Some of my young colleagues do that because they don't have to do on calls. Okay, if that floats your boat, if you think that I would rather devote myself, I would like the intellectual pressure of being a certain kind of surgeon, and I will take the challenge of that, that's fine. The United Kingdom is very, very supportive of female surgeons. I am supportive of anybody who wants to be a surgeon. Right, we will bend over backwards to, you can train part-time or less than full-time is the correct term. You can come out and be a consultant, do a job share, so you're not there every single day. Okay, and we are trying, but we are not the best at it, by the way, right? The best at it are the Northern Europeans. Okay, the Danish, the Finns, and so they are the truly evolved people on this planet, not us. Okay, they know how to do this correctly. All right. My thing is that this great big intellectual resource that just happens to be wrapped up in a female body, we can't just exclude it. I want to bring you in so that you guys play your part. Okay. This is my view. This is the exact opposite view to Afghanistan, by the way. Okay. And I'm very proud to say that. Okay. Sorry, is that too contentious for you?
Good. No, not for maybe for some.
Yeah, I'm known to be politically very correct, so I hope that was politically very correct.
I would agree. So good to know that we have a spelling support here. So Dr. Kravitz, what are your thoughts on female surgeons? Are they a vanishing tribe, or are we bound to see more of female surgeons?
I'm surprised and not surprised. All over the world, we have the same situation. We have a lot of women, girls, students in university, and not a lot of surgeons. But we have changing in this situation all over the world, because now we have a lot of women who don't want to have a baby, and they have different aims in their life. That's why in one department in our one hospital in Odessa, we have 50% of surgeons, thoracic gynecologists, and endocrine surgeries as women, and I think it will be changing in time, and I know that we have almost all gynecologists, surgeons, it's women, not men. I know maybe one gynecologist man who makes surgery. All other gynecology surgeons are women. That's why I think it will be in future changing this situation. And I think that plastic surgeons can be women. And how we can change it? I agree with all previous colleagues that we can change it only with support, because if we will help, everything will be fine. Because 24 hours our duties, it's very bad, not only for women, it's bad even for men. That's why if we change our timing, if we change some format of our work, it will be normal for everybody. It's my thoughts.
That's a great point of view.
Can I interrupt and ask one question for Konstantin?
Yes.
You said about a lot of gynecologists being women in Ukraine, which is kind of the situation in India, I'm sure. The thing, what I wanted to know is how many of them are cancer gynecologists?
Cancer gynecologists. Oh, it's very good question, because in this situation, most often it's men. Yes. But I think that about 20% it's women, but 20%. In situation of cancer, it's very difficult situation, and we see increasing of percent of young cancer in women and increasing of cancer in women. Yes.
Right,
and I think that would probably be the same in India as well, isn't it? I mean, you would find a lot of the gynecologists who do actual gynae cancer surgery are men, aren't they? I mean, and there are few women, but I think, would you agree? I mean, all our panelists were in India.
Yes, I would agree, because my mother, she's a cancer patient, cervical cancer patient. So all her medical oncologists and surgical oncologists, the doctors we've consulted, all were men. Only one doctor we consulted, she was a woman, and that was a good change and a very progressive change that we noticed. So yes, definitely this is the condition here in India. So this similar question was asked in the Indian panel discussion as well, which we had at 2 o'clock. And it was really interesting to know that the surgeons and the doctors, they highlighted this point, and even Dr. Kravitz highlighted this point, that the support, women need more support. The family has to be very supportive, and they have to be there. They need to understand that, okay, if she's not back home at the designated time to feed their children or to cook for their family, it's okay. They need to step in. And as Dr. Sanjeev also mentioned, that he supports his wife and gets her a latte daily. So that's what we need. We need supportive men, supportive family, like you all to support the women in surgery. And definitely We can see that happening progressively here in India, and different surgeons had a very nice and progressive take on this. And the numbers here in India are definitely changing. We are seeing more of women in surgery, and because of this progressive change and this evolution that is coming up in the medical fraternity, and I'm pretty sure it's the same everywhere. As the panelists mentioned, that in United Kingdom there are a lot of supportive schemes for the women, for the maternity, the liberal leaves for maternity, the maternity leaves and all. So slowly, we are also adopting the same support and the background here in India, and definitely we can hope that more and more women join in surgery, and we can hope that we see more female surgeons in future. Okay, Dr.
Right.
Tanya, you can. I would like to ask Dr. Manikandan, how is the the situation in your specialty, in the transplant specialty? How many women do you come across in your field?
Okay. So before that, as you mentioned, the reason why women doesn't take surgical specialty in India is predominantly cultural, because like at least 10 years back, like I would say my generation, the girls, whoever, means in my undergraduate days, there were 74 girls and there were 26 boys. This is my batch. Okay. So as the other speaker mentioned, so many girls were taken up, but when we speak to them, they're all brought up in a way that, okay, women, okay, you finish it, you take a specialty which keeps you calm, you come back home, you have to look after your family. If you become too much specialized, it is difficult to find a guy for you to get you married. And then the women are all brought up with a mindset of telling that you are not strong enough to stay for a long time. You cannot stay for the whole day operating. You have your own problem. This is how you are all brought up. But for some reason, obstetrics and gynecology is always dominated by women. And again, I'm telling, obstetrics is one field which has majority of emergencies, and women are trained in handling those emergencies. And I am pretty sure obstetrics and gynecology is not without complex surgeries and long surgeries. So any qualified obstetrician or gynecologist will be in a situation to do complex surgeries, dealing with complex situations, emergencies, and long surgeries. It's just a mentality. But in the last 10 years, it has been so much of change I could see. So if we take the number of generals, I was speaking to one of the general surgery directors recently. So they were telling that at the moment, the MS general surgery trainees, 40% are girls, okay? And even orthopedics, which is considered as only the male-dominated specialty, women are there doing orthopedic specialties also, okay? In terms of super specialty training, okay, so in Amrita, the first 10 batches which had only men, in the last 4-5 years, now more than, like out of 4 or 6, we have like, at the moment, we have 50-50 women and men. So women are coming in, okay? And I am greedy here to tell that whoever women, even in the level of general surgery training or special training, they always outsmart their peer men trainees for some reason. I don't know why, because of their skills or their patience or whatever they do. In transplant surgery in the UK, again, I would say, like, see, the mentality among the surgeons in the UK is completely different. You have so much of independence in deciding what do you want, and no one influences you, unlike India. So in India, your parents will tell, do this, do that, or we will be cornered by our colleagues. So someone has done this, or we need to do this. But here, the kids are brought up in a way that they are so independent in taking decisions. The interpersonal competition is very, very less. Okay. Again, people don't take transplant surgery here much, just for the fact that it's not because of the fact that they need to stay long. The fact is because they want to have a good quality of life. That's all. That is common with both men and women. Okay, it's not, I would not corner women for that. So I would say 20% of transplant surgery trainees and transplant surgery doctors are still women here, and they all do very, very well. And I personally feel, I don't want to comment about gynecologists or obstetricians here, because my wife is a gynecologist, and at the moment she's not working and she's sitting at home looking after my kids. But in terms of general surgery, I should tell that women should come and take it up. There's no difference.
Thank you so much, sir. And I would like to share my personal experience when I got admission in MBBS, and now I'm I'm planning to step into the surgical field, like my specialty. I want to pursue in surgery. So I came across this relative at some function, and that lady, her own daughter herself, she's a neurosurgeon, and the first thing that she told me was, don't take a very don't take surgery, don't go for neurosurgery or cardiothoracic surgery, because you will not end up getting a nice guy. You will not get a guy to get, you'll be all alone. Now I'm finding a guy for my daughter, but I'm not able to find it for her marriage. So yeah, definitely this is the situation that we're facing here in India. And luckily my parents are very supportive, and they're like, don't listen to all these things, just focus on your goals. We are there to support you. Things will happen on their own time. So that's really great. But this is the situation. We are slowly evolving, but it's okay.
Hang on, if you have to give up on your ambitions and dream to get a guy, is that the right guy for you?
Definitely not.
Definitely
I don't believe in that. I don't believe in that. I've got 2 daughters, and I've told them they have to do what they want to do. And if some guy wants to have the privilege of being with them, right, they have to play the game. I feel sorry for my daughter's boyfriend, by the way. Poor guy. I really feel sorry for him. But if you're a driven person, and if you're a driven person in surgery and you have long hours, you're looking for someone, whoever is your partner, to be able to support you, because the family is very important, as Chandrika said, okay? But one of the 2 has to be able to help with the family, okay? And that's the way it is, really, okay? But don't give up on your dreams, ladies. Oh my God.
Unfortunately, sir, even now, India is like that. Even now, the parents of women doctors, they feel that once they finish MBBS and if they enter super specialty, the number of guys potential guys who can marry their daughter comes down drastically. So they're all forced to marry their daughters before they enter post-graduation.
Yeah, marriage is overrated, girls. Don't worry about too much.
Another thing is we have this belief of a women doctor cannot marry a non-doctor guy. This is a thing. And unfortunately, we don't have many guys doctors, because as I told you, and if you see 70% of doctors in India are women, 30% are doctors. So we don't have an apt doctor boy to marry a doctor girl. That's the situation now, unfortunately.
My son's training to be a psychiatrist. He's single, girls, by the way. All right.
Thank you, sir, for that information. Potential female aspiring surgeons, you can connect with Dr. Sanjeev for that. But yes, definitely, I do agree with Dr. Manikandan. The spectrum decreases. That's what is believed in India. And even Indians do believe that the more the girl is achieving, or she's at a pedestal, or if she's achieving a lot of things, she won't be apt for the household work, and she won't be
Oh my God! Yeah. Break the mold, girl. Break the mold. You are India. Break the mold.
I think it's not just the family alone, I think even women by themselves, see, you wouldn't be surprised to see in the UK or even anywhere in the Western world, you might find a surgeon or, or somebody in a big position, like even a banker, a woman might be in a very high financial position, but she wouldn't hesitate to marry a plumber or an electrician. That wouldn't, as long as the guy is compatible, they would be happy with that. Whether by the choice of the girl or the family will have really no say in it, and the woman would be happy with it. But I will dare ask, are there any doctors here who will say, I'll be happy to marry a plumber or electrician, however, whether he looks like Shah Rukh Khan or whatever good character he had. I still will dare, even amongst this entire audience, how will you dare to marry a carpenter or an electrician? You won't. That's basically it. I think that's how we're brought up. And I guess until that also changes, it's not just blaming the family alone, I would say.
It's the mentality of Indians, that the sole basic thinking process that should change.
Yeah, which is why when the neurosurgery lady, she's expecting a guy who's equally qualified. She's
Yes.
probably not going to be happy with a guy who's just an MBBS, a family practitioner. Even if you had a family practitioner guy, the mother might not be happy, or even the girl may not be happy, or the guy might end up with some inferiority complex. These things happen, and that's, as Manigan said, truly cultural. That is the problem. I guess until you break that mold as well, it's going to be difficult.
But each of you can take a little hammer and start hitting the mold, yeah? To start breaking.
We are doing it, sir. We are doing it.
We are doing it, yes. And with your groundswell of support. So it's really good to know that they're as capable or even more, and we do not need to find a guy at par to be ambitious and go forward in life. That's amazing. And it was lovely hearing that.
I completely agree with what Manikantan said earlier about women in obstetrics and gynecology. And if you can do obstetrics and gynecology, then you can do anything. And I've actually seen more and more people, women gynecologists, going into gynae oncology. In our trust, there are 2 women gynecologists who've gone into oncology. And I think it's just the support you get from your family. And if you have the support, you can achieve anything. And I've just got my fresh cup of tea from my husband. So
I was saying, wow.
That's really amazing. Like, wow.
Dr. Sanjeev's making another cup of tea tonight.
I have to take her out to dinner after this. So,
Well, that's very nice of you. Well, so that was a beautiful talk on women in surgery, and I'm sure we're all extremely inspired by that. So I'm just going to switch to the next question now, because a few delegates had asked and had queries on research. So we all understand that research is a very vital part of tomorrow, and keeping up with the times means thinking well ahead and exploring all the options that are available. So what opportunities does the field of research have in surgery? Because in medicine, there's quite a bit, but in surgery, we do not hear as much about it. So could you please enlighten us on that? Dr. Chandrika, would you like to go first?
Yeah, I mean, the opportunities are always there. I think it's just a question of taking up. I mean, if we look at it, we don't even audit any of our figures in India. We kind of wing it as we say it, whatever we do, it's always personal experience. Yeah, I always did this. And nobody sits and documents everything. Documentation is rather poor as well, which probably contributes to the lack of research thing. And again, it's a fact that there is a lot of people in India, and everybody's having private practice as well. It's a necessity of life over there. So I guess the fact that people wanting to do true academic research does get reduced. And also there's no requirement. I mean, people all become professors. Like if you see in the Western world, you don't get these academic qualifications. You get to be a doctor, but you don't become like assistant professor and all that without X number of papers and publications and all that. Whereas that's not always the case in India. I mean, you'd find not just in medicine, in other things as well, there are loads of PhDs and MPhil people. It's like dime a dozen, isn't it? And I don't know how, I mean, not just in medicine or surgery alone, about the research part of it. So I think until we start having a good documentation about the cases we do, I mean, I have to say, I have been out of India, work in India for 20 years or so I can't really say how things have changed, but I do know places like Tata Memorial and all that, they do quite a lot of good work. So yeah, there is a lot of scope, but I think it was all going to start. And we don't get taught these things. I mean, we get taught lots of stuff in MBBS, but there is no pattern or anything to teach about statistics and how you evaluate, how to read a research paper. None of these are taught even at the postgraduate level. And I guess until we get taken through those things, it might be difficult. And that might be something our educators have to look into and see, how to incorporate that, to see how to read a paper, how to read the statistics, how to comment on it. That should be part and parcel of the master's training program, I think.
Absolutely, ma'am. It should be added to the curriculum so that everyone gets a view of what's going on, keeping up with the times, and have their own viewpoints about it too. That would obviously be for the better. But thank
I
you
don't
so
know
much,
whether you
sir.
have journal clubs anymore there. Do you keep discussing? I mean, we used to have in certain places, but not in everywhere. But I don't know how much it works and how much is talked about. Again, there's one thing here. We have these regular morbidity and mortality meetings, which is like a must in UK. I mean, not just in UK, in all the Western world, they have this regular thing. But I'm not sure. I mean, I didn't have it when I was training in India. There was no such thing. So that kind of personal introspection and also to be able to evaluate your numbers and figures, be honest, at least amongst ourselves, forget about the general public, at least within the medical profession, within the surgical profession. I think that kind of honesty, I think it takes a bit of time to develop. And I'm not sure whether that started in India, maybe in certain places, but I don't know whether it's universal. I doubt it. But I'd be happy to listen to what you guys have to say about it at the moment there.
No, there are a few journal clubs. We've started with research programs. And even Clinicase has its very own research unit of Clinicase Assam called RUSE. And we're actively doing 2 researches under that wing. And tomorrow we have a talk on the surgical research program. We've invited 2 researchers from the different colleges who have actively been participating in different surgical researches and have a lot of work done. So we have that talk tomorrow so that our students and delegates get an insight into this program. And apart from Clinicase, there are different organizations and associations that are doing active research work and are spreading this awareness about research being a very important part of our career, not just the postgraduate career, but right from our UG, undergraduate, it should be an integral part of our curriculum. So
you are in Bangalore, Shivani, and the Indian Institute of Science in Bangalore produces some of the best researchers in the world. I mean, I've had chances to meet a few of them when I was in the States as well. And they are really good. And I always wondered why we've never had the exposure to such people to give us some, even like you said, even at the undergraduate stage, to bring in some of them to tell us about some of the basics of what research is and how you do go about it and all that. And it's a pity we don't utilize our own resources. I mean, you are in Bangalore, and I'm talking Indian Institute of Science, which is in Bangalore, which is a fantastic place. And I'm sure, I doubt anybody's ever cooperated with those guys to bring in those guys as well, to start with some epidemiological work or whatever, at the simplest level, to do that. I don't think they've done it. I mean, I'm not sure. You can correct me on that.
We have a student from Bangalore Medical Research and Institute, Ritika Sakhare. She is our junior executive officer for research for RUSE, and tomorrow even she'll be talking upon this topic. And currently she's working on 3 projects, one being on breast oncology. So we have one student from there who is actively a part of Clinicase and helping us out spread the awareness.
I think research is considered a luxury in India. Possibly that's what might be the case, because
and students need to learn that it's a necessity, not a luxury.
Exactly. Yes. I just hope as many opportunities rise up or students find such opportunities to take up. Dr. Manikandan, what are your views on this?
The same thing. So I think it has been discussed in detail, but so research in India, at least means from the undergraduate. So I remember that I had done some short projects with ICMR when I was an undergraduate student. And then during the post-graduation, as a part of the thesis, we all know as a surgical training, we all know how we do our postgraduate thesis. It's bullshit, actually. No one does it properly. Okay. And that's because of a previous generation of doctors or the teachers. So what happened is they're all brought up in a way that means 90% of the importance is given to the clinical aspect and no importance was given to the research aspect. And that difference is huge when we come to the West. So in the West, for any profession, either it's a consultant or a trainee, I think it will be either 60/40 or even 50/50, or some people take like 70% research and 30% clinical job. So research, auditing, publication is a part and parcel of the job here. But on the other hand, for people in India, they consider it as so much of burden. And we all have the mindset of having, so even if we do something, we are so flexible enough to manipulate things to bring some result out of it and make some publication, which is completely wrong. I have also done it. So to be very, very honest. So that's again because we don't have enough exposure of the importance of research. Why do we need to do research, and basically the research methodologies, which is not completely taught to us. And I'm pretty sure 90%, 95% of the teaching institutions in the country, up to the super specialty training, we don't learn how to do a proper research. It's completely a different ballgame in the UK. So from the beginning, like if you are a FY1 doctor, the FY1 doctors try to participate in the institutional audit. So they need certificates of participation before they enter into FY2. From FY2 to CT1, they need some kind of participation. So again, as they move from FY1 to ST3 or ST8, they'll be a junior researcher, and then they slowly move from step to step. They will have so many opportunities here to participate themselves in various research activities of the institution, and by the side, they'll learn so many things. So I feel the opportunities for research in the UK is like 100 to maybe 1,000 times more than what we have in India. At least 10 years back. I don't know how the situation is now.
Can I just say one more thing? It's also, I think, with our schooling itself, or even going into college, there's a lot of spoon feeding in the teaching. Whereas in this country, right from the very age, it's very self-directed learning. And I guess that's possibly one of the bigger factors as well.
Very true. So if you see for us, so for each, let me say, first year MBBS or second year MBBS, we have specific textbooks for each subject, which is recommended by the universities. Here, we don't have any recommendations at all. And again, the teaching here is completely different. They don't have specific subjects, first year, second year. It's based on system-based teaching. And they will just tell, these are all the resources available. It is up to the students to go research, find their way out. So this is how the training here is. Yeah, that's a very good point. Yeah. Yes. And we also, and because and apart from the international textbooks which we have so many shortcut textbooks, and we all tend to go into those shortcut textbooks and we learn, and everyone does that because we are in a situation that we need to finish our qualification first. The training, the learning all comes next. That is how we are all brought up. So if we fail or if we take a break, say for example, like when I tell my Indian colleagues that I am doing some training 3 or 4 years now, they'll ask me, why are you wasting time here? But if you see here, after finishing their medical school, they take a break for something. They'll tell that I'm going out for a travel. They go for 3 years, 4 years travel. They come back and they start their training again. Like they don't give much importance of wasting time. They want to do what they like. And here the quality matters than the quantity, which is the complete difference between the teaching or learning between the East and the West.
That's quite true, sir. While skipping on from one exam to the next, we often miss out on the learning and the understanding part of it. Yeah. And yes, the quality does go down. Yeah. Yes. Okay. Since we are a little short on time, I'm just going to take the next question to the other panelists. So this one is on the healthcare system in UK. So Dr. Sanjeev, this one's for you. So if money were to be taken out of the equation, how would it affect the treatment of the patient, since NHS is renowned for its uniform and free healthcare system?
Yeah, I think the correct term for the NHS is that healthcare is free at the point of delivery. That's what it is. Okay. And that makes it a hugely pleasurable place to work in, because when I go to work, if I see 100 patients or I see 10 patients, I make the same money at the end of the month in the NHS. Okay, right. So that takes away a very important thing, and that's called a perverse incentive. I don't have a perverse incentive to see more patients. I don't have a perverse incentive to say, I will do this test on you, or this operation, or this or that or the other, because I will make more money. Okay, now I have a sister who lives in the United States, and I've seen her healthcare, and I must say it's very obvious to me that is affected by financial gains a lot of the time. Okay, it's not to say that that doesn't happen in the UK. It does, but it happens in the private sector in the UK, where when you go to the private sector, oh yeah, you may need this test and that test. Okay, so but in the NHS, it's the most pleasurable place to work, in as much as you can do what is right for your patient and don't have to worry about how much money you're making for the NHS, because they're not paying. okay? And then I can be a doctor for the sake of being a doctor and follow what I have always wanted to do, which is look after my patient. I'm very socialist. That's a weird thing, socialist and plastic surgeon, but trust me, I am, okay? All right, so I completely believe in the NHS, free at the point of delivery. And I'm sure my colleagues in the UK will agree with me. If they don't, you can mute them, yeah, when they're saying anything else.
Absolutely. So it's great to know that being a doctor, you're going to be able to provide everything to your patient and that it is going to be available to them, which is quite opposite of what happens in India, because you come to a government hospital and then it's very hard for a patient, even when a medication is available, but then they can't afford it, or they cannot afford a test to diagnose something. So that's a great system they have there with the free healthcare system at the point of delivery. Thank you so much.
Tanya, you can't just go on completely saying it's the greatest system. Yeah, Sanjeev, what Sanjeev said is correct on the part of that you can provide in hospitals, but I can tell you here, you will wait for sometimes years to see a specialist. You will wait for appointments and appointments to see, you can just have a hernia and you'll probably wait 14 to 18 months to see a surgeon, just to be get on to be booked to be arranged, and the surgery might happen later. Whereas in India, you have the opportunity, you'll just walk into the general hospital and you will get seen and you'll probably be operated that same week. Yeah. So I mean, yes, we have that. So that there are pros and cons. I agree with Sanjeev that you say you don't have to think about the money. Like you can, if you want to do something for the person, you're not thinking of the money. As long as the hospital is able to provide it, you will be able to do it. Or like he's doing transplant surgery, you can do that, whatever, it doesn't matter. But then, if it's like simple conditions or even waiting to see somebody, it does take a lot of time. And that's one of the biggest complaints you'll hear here. Like right now, you can't, getting a face-to-face appointment with your GP is getting very difficult after the pandemic, which is when you only get a telephone clinic. And probably when you ring at 8 o'clock in the morning, I don't know what it is in Wakefield, Sanjeev, I'll leave that there. But in London, around this area, at least if you ring up the GP, at 8 o'clock in the morning, which is when they open, within about 10 minutes, they'll only have about 20 slots, and the 20 slots are taken. They say, try again tomorrow. So, these are the kind of complaints you get. So you have a different kind of problems here. I mean, the problems are there, but it's a different kind, I would say.
I think just to say that's exactly correct. No system in the world is perfect. But I guess in defense, in the United Kingdom, if you can't wait and you have money, you can pay and see a surgeon next week if you want. You know what I mean? So
but the same thing in India, Sanjeev. If you can't pay, if you can't wait for the energy, you go see. But what I'm trying to say is there is a chance, because I'm talking from my experience 20 years ago. It might have changed now. But I know people would walk in to the outpatient department at 7 o'clock, get admitted for a hernia or a hydrocele or thyroid or whatever, and they will be operated that same week. Yes, they may not be sitting on, they all will not get a bed. You'll probably find them sleeping between the cots, under the cot, etc. All of the patients may not have a bed. They'll be on the floor, but then they will get the surgery. Is that correct, or has it changed now?
No, ma'am, it's correct. Here in India, if you ring up the doctor even at 12 a.m. at night, which I have done actually in case of my mother, the doctor is still available. And I'm glad that in India, the doctors and the patients can easily access the medical facilities. And personally, when my grandfather had a minor attack and he had to get admitted, so we didn't have an appointment with the cardiothoracic surgeon, but we just walked in and he took us because it was an emergency case. So definitely in India, you can approach the doctors as and when required. So they'd never ever deny their service.
Yeah, so can I just, I've got to point out that acute healthcare and the national health is par excellence. If you have a heart attack, you will get looked after. I think what Chandrik was talking about is more sort of elective surgery and the waiting list and this and that. And what we have is a large population and not enough doctors. So first of all, I'm hoping some of you guys come across and train and stay so that we can keep you. The good ones, the bad ones, we're going to throw back, right? We will do the brain drain from now, okay? But that's the problem. We've got a very large population. If you go to somewhere like Canada, I have another sister who lives in Canada, their population is small, okay? But in the cities, even in Canada, the waiting lists are 1 year, 2 years, and 3 years. Okay, so it's a numbers game, isn't it? So if you pay money, you get done. If you don't pay money, you pay with time. You always pay. Nothing. There's no such thing as a free lunch. Yeah.
Sanjeev, don't say that you need a brain drain from India. You're saying this is a big country. What about India?
Yes.
Yeah. So the
I'm being
population here and the students
I'm being
here.
totally selfish. I'm unashamedly being selfish. I apologize.
You're just bringing them in for your old age, is it?
Oh yeah.
Don't challenge Indian students. They are very egoistic like that. They'll take up a challenge and prove you wrong. They'll stay back in India and strengthen the fraternity.
We are very
This
nice.
could backfire badly.
Yeah. So, definitely. Thank you, Tara. You can continue.
Yes, so unfortunately, since we're short on time, we're going to have to conclude this panel discussion. I know the delegates have a lot of questions to ask, but this has been going on for 2 hours and it has been a wonderful, wonderful session. So I'm concluding this. Thank you so much, panel, for giving us such an enlightening session. It was an honor hearing such insightful words about the scope of surgery abroad. I am sure it has inspired many to pursue the path, and we're extremely grateful for your presence here today. I know you all have extremely busy schedules and you all fit in this timeline, and you are here today. Thank you so much for that. And thank you, delegates, for being such an enthusiastic audience. We're sorry we couldn't answer your questions, but you were great, and thank you so much for being here. So,
I would like to add a few words.
Absolutely,
Tanya, if I may.
absolutely.
Yes, I would like to thank all the panelists today. Thank you for accepting our invitation and being a part of this panel discussion. I hope you had a really great time talking to us and discussing. We've touched upon varied topics, and it was so great to hear different perspectives. And the delegates, I'm pretty sure they had a really nice and enlightening experience. Definitely, we can connect again sometime in future. And thank you, Dr. Sanjeev, for bringing up the humorous and really quirky perspective to the panel discussion. Like usually people think the panel discussions are very formal and very professional, but this was my first experience where we were so comfortable with each other and we were so casual. So
I'll wear my suit and bow tie the next time. If I get invited back. If I get invited.
Definitely, sir. We would love to have you on board.
Please don't lose the skeleton, though.
Can I just tell you, delegates, one thing? If the apartheid system in South Africa can be broken down, any tradition in the world can be broken down. Okay, remember that. Every little hammer will break the mold eventually. Okay.
I am going to quote this in future.
Yes, please.
Yes, if you give
I feel
us permission.
I feel like a standing ovation is due right now.
Yes. So we can conclude the session by taking a group picture. I would request the delegates to switch on their cameras and for a group picture, please. Anna, can you please take the screenshot of the picture?
Harshwani, I can't see all of the participants on my screen together.
Can you see them now?
It's on my tab. I'm not able to see more than 4 participants at a time.
Oh, okay. No worries. I'll take them. Okay. Delegates,
children.
Please
oh my God, they're all kids. Oh my God, how old are you guys? Like 12. Oh my God.
12, sir. We're 12.
I think you guys did a really good job organizing this, by the way. I'm sure I speak for the rest of the panel. I'm very impressed by this. Aren't we, guys? We very impressed by this.
Absolutely, yeah.
Absolutely, yes.
And the weirdest is that you guys managed to bring someone from Trinidad to meet up with me in this. That is, the chances of that are phenomenally small, is infinitesimally small. Yeah. But
that is right.
Even though she works in London, I mean, can't have everything, really.
Sanjeev, I'm actually honored to meet Manjula. She works in the same hospital and I'm just meeting her here.
Oh, wow.
Even though you work in Newham.
Yes, it's not like that in Wakefield. All the doctors, well, I know all the doctors anyway, but I've got a big mouth, so people know who I am.
Okay. Thank you so much. We've taken the picture. Thank you so much, everyone, for joining us. Tomorrow, please tune in again for the surgical research program. I hope the delegates are having a really nice time at Icon Surgery 2021. Tomorrow is our last day, and please do attend the closing ceremony as well. We have few winners to announce tomorrow, and a little throwback of what we have covered in these 3 days. So see you tomorrow. Thank you so much. Good night.
Bye,
We'll be ending the
guys.
meeting.
Thank you.
Thank you.
Bye.
Thank you
Thank you.
so
Bye-bye.
much.
Bye. Bye.
Bye.
Have a great day. Bye.
Bye. Bye.